We're ready to go.
Thank you, Kathy. Now I will call the meeting to order and start with the roll call. Kathy, if you could do the honors, please.
Absolutely. Rebecca?
Here.
Michael?
Here.
Elaine?
Here.
I'm going to call Bella. Not here. Eric?
Here.
Martha?
Here.
Robin?
Here.
Dimitri?
Good morning, Nancy. I'm here.
Secretary?
Here.
Nancy?
Morning, Kathy. I'm here.
Morning. Erica? She was there.
Okay, is that everyone? Great.
I'm here. Sorry about
Okay,
that.
that's
Hello.
okay. Yes,
Oh,
that's
sorry.
it. Thank you,
I see
everyone.
you. Okay.
Oh.
Thank you.
I'm sorry, Secretary. Kathy, I just want to apologize. I think I accidentally referred to you as called you Nancy. I said good morning to you.
And why would that
I
require
take
an
it
apology?
I take it as a compliment to me.
And yeah, I was thinking maybe there's ways we could spice up this roll call, like do them in different languages or something, but or call each other by different names. So with that very inappropriate and probably illegal suggestion, the first item is approval of the minutes of the June 13th meeting. I'll entertain a motion to approve the minutes.
So moved.
And a second, please.
Second.
Thank you. And Kathy, can we do the roll call? Probably in English, but
And in the same order.
Yeah.
Okay. Rebecca?
Yes.
Michael?
Yes.
Elaine?
Yes.
Eric?
Yes.
Martha?
Yes.
Robin?
Yes.
Dimitri?
Yes.
Secretary?
yes.
Nancy?
It's just too tempting, Secretary. Ja, merci, yes.
Yeah.
And Erica?
Yes.
Thank you.
Wonderful. Thank you. Thanks, everybody. The motion carries. So we have a lot on the agenda today. So I'm going to turn it right over to Audrey for the Executive Director report. Thank you, Audrey.
Thank you, Secretary. Good morning, everyone, and welcome to our July board meeting. We do have a range of substantial items on the agenda today, and I look forward to our discussions and your insights throughout. Before quick previews on our topics today, I want to first take a moment to note a new slide you will see in today's presentations and in our board presentations going forward. This slide will explicitly highlight the link between the given agenda item and two standing priorities of the Health Connector. One, our 2024 to 2028 strategic plan, and two, our commitment to using the levers, resources, and weight of this agency to combat racial and other inequities here in the Commonwealth. Including this information, these linkages in every presentation ensures we're perpetually considering the four pillars of our strategic plan and our commitment to advancing equity in everything we do. Our goal is for this to more easily provide you, our board, and the public with a clear and articulated through line between our daily work and our long-term planning and the ambitions we've set together. Heading into the agenda itself, today kicks off with our conditional 2025 seal of approval presentation and vote. One of our seal of approval goals for 2025 was to provide stability for members and carriers after the significant changes we implemented for 2024. And we see this objective reflected back in the responses that we received from carriers. Significantly, however, we are mindful of the potential for disruption in 2025 related to an ongoing situation with WellSense Health Plan and the National Committee for Quality Assurance, or NCQA, which saw WellSense fail to renew their accreditation recently. This kind of accreditation is generally required for marketplace participation per federal ACA regulations. We are working very closely with NCQA and WellSense, as well as with our fellow state agencies, Mass Health and the Division of Insurance, as WellSense works through a corrective action plan to meet NCQA's standards. This includes regular independent meetings between the NCQA and state regulators, ourselves, DOI and Mass Health, that will take place between now and our September board meeting, when this board will vote on the final seal of approval for 2025. We will share learnings from these discussions with the board as they unfold. We're focused on two main areas going forward. One, to date, members haven't seen direct negative impacts from the lack of reaccreditation. We will be keeping a close eye on this area to ensure our members' needs are being met, our highest priority. Two, we are simultaneously conducting contingency planning in the event that WellSense is not sufficiently progressing towards reaccreditation by this September. Internal operational preparations for 2025 open enrollment officially commenced in late June, and this issue is already being gamed out as we ensure we are ready for any contingency based on the result of WellSense's work. WellSense and the Health Connector have a great deal of work to do between now and September's final seal of approval vote, and we are hopeful that WellSense's progress allows them to remain on our product shelf in 2025 and beyond, but we will be prepared if that is not the case. I want to express my appreciation to our policy and plan management team and legal team and others involved in preparing for open enrollment for the careful, deliberative, time-consuming work they have had to take on to handle this unexpected circumstance, on top of the already intensive and demanding work of our annual seal of approval process. Also on the agenda for today is the presentation for our FY 2025 budget and a recap of the FY 2024 budget. The proposed 2025 budget was reviewed and approved by this board's Administration and Finance Subcommittee at the end of May. With thanks to Carrie Miller and our finance team and our subcommittee members, we're pleased to be able to present a balanced budget, which responsibly accounts for contingencies for the future of our customer service and technology operations, and also maintains adequate reserves to meet auditor recommendations of 6 months of operating expenses on hand. Lastly, today we will also provide an update on our pilot expansion of ConnectorCare, which is now delivering more affordable health coverage to more than 51,000 people after being implemented just over 6 months ago in January. Since that time, we're grateful for the fact that CMS approved federal financial participation for this program via Mass Health's 1115 waiver, cutting state costs for this expansion in half. In our discussion today, we will review key demographic and other data about this new population, and we'll provide insights and commentary from the nearly 2,500 pilot expansion members who responded to a survey last month. 9 out of 10 respondents said they have already used their coverage, and 2/3 said that their copays are affordable. Enrollees are also reporting that they are getting preventive care or prescriptions that they had previously put off because of cost, or are now seeing a specialist when they had put it off in the past. Enrollees are also reporting to us that the pilot expansion has helped ease cost pressures in their household budgets, with enrollees reporting that new savings thanks to ConnectorCare are allowing them to save towards groceries, utilities, and paying down student loans. After our team sprint to implement this pilot, between it being signed into law and open enrollment last year, it's deeply heartening that in just a few months, so many of our residents are now better able to access the care they need to keep healthy while also stabilizing their household's financial security. Before we move into the presentations, I'd like to quickly note 2 other items. First, last month, we completed our latest Navigator grant procurement. As you all know, our Navigator program provides funding, training, and support to a network of community-based organizations and individuals that provide multilingual assistance in person to people navigating our enrollment process and working to remain covered. Navigators provide help in about 30 languages, providing support and delivering their know-how in the best way possible in their communities. With the addition of 3 new organizations, 1 each in Boston, New Bedford, and Framingham, as of July 1st, we now have 24 organizations providing excellent in-person assistance to the diverse communities they serve. The last year was a busy one for Navigators due to the Mass Health redetermination process, and they helped get or maintain coverage more than 200,000 times over the last year. We're grateful to our Navigator partners who are the known trusted face of the Health Connector on the ground in the community. And I also want to give a special shout out to Sarah Bonapane from our team, who has been a tremendous leader for this critical program for many, many years and keeps the entire Navigator enterprise excelling. Lastly, to end on historic news about which this board and my team should feel a special pride, last month our colleagues at the Center for Health Information and Analysis published its 2023 Massachusetts Health Insurance Survey results, which recorded the rate of insurance coverage here in Massachusetts at 98.3%. That is the highest recorded rate of health insurance in Massachusetts history or anywhere in the United States. The survey was done between April and August of last year, so much of the Mass Health redeterminations work was still ahead of us. But for a variety of methodological reasons, the CHIA survey has long been the gold standard for measuring coverage rates, and having such an impressive number at that snapshot in time is quite simply a remarkable accomplishment for the Commonwealth. Massachusetts didn't reach that level of coverage without your support, input, and continued urgency around delivering access to coverage to everyone and driving this organization and its promise ever further forward. So thank you, as always, for sharing your energy and drive with us, and I look forward to the rest of today's meeting. I'll hand it back to you, Secretary.
Great. Thank you so much, Audrey, and really congratulations to everybody on that incredible incredible accomplishment. Before we start on the next conversation, I just wanted to share some conversations that I've had with Audrey and through her with the Connectors Council on whether I should participate in the conditional seal of approval conversation, because it affects WellSense, which I was responsible for at Boston Medical Center. And I think there's no legal obligation for me to recuse myself, but I've learned from chatting with lawyers that if you feel there might be a conflict, that, you know, if you feel it in your stomach, you should, you know, maybe recuse yourself. I would also, but I think it's a really important matter for us, and it affects other parts of the world that I'm responsible for, most notably the mass health process, which ACO, which has the same standards. So what I think I'll do, and I will not chair, but I will listen during this part of the conversation. So if anybody on this call is uncomfortable with me doing that, then I will, you know, log off and log back on for the rest of the meeting. So, but I'm open to, I really am asking for feedback here. So if anybody feels like I should not even listen, that's good too. I'm seeing head shakes, show of hands. Okay.
Feel
So
fine.
I'm sorry, what?
No, I just said I feel fine with you staying on.
Okay,
As
But-
do I, Secretary.
great. Okay, but
And
Fellaini,
so do I.
okay. You know me, I'll probably pop up with a comment or two, but I will really try hard not to. But I do want to listen and learn, and I really appreciate all the work that Audrey referenced in her opening remarks on trying to get this right, because it's an accreditation issue, but it's fundamentally a coverage issue, and so want to make sure we get it. So I'll Fellaini, thank you so much for taking over, but I will be on the call and listening carefully. Thank you.
Absolutely. Much appreciated. And it's always good to listen to your gut on any of these things. And so, and next on the agenda, as the secretary mentioned, is a presentation on the conditional seal of approval for next year's plan year, and it will include a vote. And so I'm going to kick it off to Chris and then Marissa, who will walk us through the presentation. So Chris, the floor is yours.
Chris, I think you're on mute.
Sorry, I guess it wouldn't be a meeting if somebody wasn't on mute. I appreciate the patience. Thanks, everybody. Appreciate the opportunity to be in front of the board today to discuss the 2025 seal of approval process, the submissions we've received thus far. As was noted, you know, when we think about plan year 2025, our focus at the Health Connector has been prioritizing stability while also finding ways to accelerate and continue making progress on equity topics, health equity topics that we are focused on here at the Health Connector. So here we have just a quick high-level view where we want to remind everyone timeline for our seal of approval process. As everyone will recall, this kicked off in earnest on March 1st when we released our 2025 seal of approval RFR, and there's been a host of activity and a fair amount of engagement with our carrier partners through their submissions as part of that RFR process. That leads us to today's conditions. We can move to the next slide, please.
Unfortunately, I'm having a hard time hearing Chris, and I don't know if I'm the only one. Just wanted to lift that up.
I am too, just a little bit.
Yeah, there's a slight echo or reverb with Chris.
All right, folks, I just turned a fan off. Is that any better?
It is for me.
Yeah.
It sounds better for me as well.
Apologies about that. Do I need to repeat any of the content from our previous slide? I'm happy to do so if people want to. Okay, seeing heads shaking, no. All right, and please do speak up if anyone's having any additional difficulty hearing me. So a quick refresher of our goals and our strategy when we think about the shelf of available options to the residents of the Commonwealth. In 2025, we're going to see continued focus on a number of health equity areas, as we had already discussed. As you know, we actually have efforts right now underway with our carriers to address foregone preventative care in the form of targeted outreach that carriers are making to individuals whom they think may be eligible for some of these services that are available at little to no cost. And so we are going to continue to focus on that, continue to look to carriers in 2025 to continue with that outreach and hopefully make some impact in that area around deferred or foregone care that is available at little to no cost. And in addition to that, we're also prioritizing, as we have discussed with this group in the past, the Healy-Driscoll administration's priority health equity focused topics of maternal health and cardiometabolic health. And what we're doing this year is we are actually layering that into our quality improvement strategies that carriers are required to submit, that they will be focusing on throughout the course of 2025, where they'll be providing baseline data on existing efforts and any additional efforts to try to address some of the outcomes within these particular areas. So here we are with a bit of a review, as Audrey has mentioned, into how this topic, our overall seal of approval, layers into our broader strategic plan, as well as our overall equity topics. And I think I would highlight that the seal of approval process, for a number of reasons that are hopefully obvious, is critical to ensuring that we have the high value coverage options that we are looking to provide for the residents of the Commonwealth of Massachusetts, which is part of our strategic goal. And as we just mentioned, baked in, right, inherent in what we do is a focus on a number of health equity topics. And if we get even more specific, we've got a few things noted on this slide around steps we've taken at the Health Connector to try to ensure that folks of all walks of life continue to both have access and actually utilize the care that's available to them through the Health Connector. And so the seal of approval effort overall is one that is well connected and immediately serves the strategic goals of our organization and ultimately of the residents of Massachusetts. Next slide, please. So here we are, an overview of the qualified health plans. And the good news is we've been discussing here is that for 2025, the product shelf remains relatively stable and is represented by 8 medical carriers who submitted a total of 48 non-group and 56 small group plans, which is very stable compared to past years. As folks may know, each issuer is required to offer a standard plan design on the platinum, gold, silver, and bronze tiers. And those standard plan designs seek to provide a co-pay first cost sharing focus on reducing costs for primary care visits and generic medications for plan enrollees. In addition to the 8 existing health carriers, we actually have 2 dental carriers who will also be looking to offer plans on the shelf for 2025. ConnectorCare plans, which as folks know are the cost share reduction variants of our standard silver plan, will again be offered by all 8 medical carriers who offer them in 2024 as well. We'll get to ConnectorCare a little bit more about that. Before I jump into this, I just wanted to pause if there were any questions or comments on the overall offering so far. Okay, here you'll see a view of the non-group product shelf. Sorry for the eye exam. I realize that the tables with all the numbers are not necessarily incredibly conducive to scanning, but the net here is that we have 48 plans that are essentially for the non-group offering that are stable year over year. Standard plans make up the majority of these offerings from the issuers, about 80% of the plans that are offering, and these are plans, again, that the Health Connector takes time to specifically design the particular cost sharing structure and available benefits. The non-group shelf, as I mentioned, remains stable with minimal cost sharing changes to any of the plans. A quick note here, when we say 48 plans, this reflects the total amount of plans that are being proposed for certification to the seal of approval process for 2025. But an individual member's choice will certainly vary depending on where they're located and what specific options are available. As an example, a current or prospective ConnectorCare enrollee in a certain area could have up to 5 plans available Meanwhile, someone who is not seeking subsidized coverage or subsidized member could have up to 20 different plans that might be available in their region. So it really can vary from member to member, region to region. All right, if no questions, we'll move to the next slide and take a look at our small group shelf. So again, stability is the name of the game here.
I'm
for
sorry, it looks like Eric has a question. Eric, the floor is yours.
Yes, thank you. I had a question on the prior slide. I'm trained to look at the footnotes. Could you let us know what that means at the bottom, the catastrophic plan?
Absolutely, and we'll get to that in a moment. So catastrophic plans are a unique plan type that are part of the Affordable Care Act that are required to be offerings that, within each state. The plan designs do not have to meet all the same specifications of a true QHP. And the way that this process has worked in the past is carriers will submit catastrophic plans, and so long as the Health Connector reviews the available offerings and ensures that there is at least 2 catastrophic available, a number of carriers. So we'll get into that in just a little bit more, but that is just noting that this includes any proposed catastrophic plans that were also proposed to be waived.
I'm sorry, Chris, you're fading again.
Gonna have to get a new mic. What I was saying was, better?
Yes.
Okay. What I was saying was the footnote at the bottom is flagging that the counts on this table do not include the catastrophic plans that have been proposed by carriers. And that is because we have a process for carriers. All carriers will propose catastrophic. Generally, the majority of carriers will request to waive those catastrophic plans for sale. And the Health Connector reviews the available offerings and ensures that there is at least 2 plans available for you. That footnote is just flagging that those are not included in these plans. So if that helps.
Okay, thank you.
Okay, so if we can, or here we are on small groups. As I was mentioning, small group shelf is relatively stable with actually the exact same number of plans from 2024 and the exact same number of carriers. A notable difference between our non-group offering and our small group offerings is, or one notable difference, I should say, is the ability for employers to select from some additional low silver plan designs, as well as additional PPO offerings. We're going to talk a little bit more about our healthcare for business offering or our small group business offering in just a moment when we get to some of our value premium approach for 2025. All right, as far as service area changes, we have one carrier in 2025, Fallon Health, who is requesting to expand their service area into certain portions of Bristol, Plymouth, and Hampton counties, where Connector has reviewed those expansions along with the Division of Insurance, and we feel that it meets all the current standards for network adequacy, and it's something that we are recommending that that move forward. It does meet our current network adequacy standards. A quick note about network adequacy standards, which we have discussed with this group in the past, is that as we look ahead to 2026, there's some new rules that are going to be in play that we're working with the Division of Insurance to operationalize around those network adequacy standards. But for calendar year 2025, we're operating under our current known network adequacy standards processes, and there's no issues at the moment known with the Fallon expansion. And then here on the right-hand side is a quick note about the catastrophic plans that I had highlighted a moment ago around the offering that Eric Boko had asked a question about a moment. Okay. So affordability for small groups. A moment ago, I mentioned that we would talk a little more about our healthcare for business offering. As many folks know, the Health Connector, as we believe, is a relatively robust offering for small group employers on the Health Connector shelf in our healthcare for business model. It offers a fair amount of flexibility in both the options that are available for employers to offer to their employees, as well as the relative value that each of those plans provides, and even the manner in which, or the type of plans in which they can offer their employees choices and selection. And so, perfect. Sorry, is there a question?
I don't see any questions in the queue.
All right, for plan year 2025, as has been discussed previously, the Health Connector is working with carriers to actually highlight some of the value premium value plans, which is to say plans that are offering better than market average premium value in their offering to small group employers. And so we'll be sharing and working with those carriers to identify those plans in the shopping experience. And the intent here is to provide employers as they are deciding on what plans to offer, as well as employees as they are selecting the plan that their particular small employer may offer, the opportunity to understand that a particular plan offers a better than market average premium relative to some of the other options that are out there. This can help with that decision-making process and the overall value of that plan. Okay, ConnectorCare program design. As we mentioned before, the ConnectorCare program is the subsidized program with additional state rep dollars. We will be including some additional information as we finalize the overall ConnectorCare program design in our September board and directors meeting presentation around the final vote for seal of approval. But what we need to know now is we're building on the expansion from last year. We currently expect to see all 8 carriers who participated in 2024 also participating in ConnectorCare in 2025. And the benefit designs are largely the same with the exception of some cost sharing that we were able to eliminate on plan type 1 for ConnectorCare on prescription drugs. As has been discussed in this venue in the past, the out-of-pocket costs can have a real impact on individuals' desire and ability to actually access services. And so I think this is one more important step to reducing some of those out-of-pocket costs for those individuals on ConnectorCare plan type 1. Final rates that are still being reviewed right now through the DOI rate review process will also be taken into consideration as we finalize our. Okay, we'll now move on. No questions to our qualified dental plans. Again, we see little change here year over year from 2024 with 2 existing carriers who have proposed the same number of plans, Altus Dental and Delta Dental. We also have 1 carrier who has proposed some plans but has requested a waiver for those plans to sell, which is consistent with years past on the exchange. But the plan designs have not changed. The available offerings that are being proposed have not changed. And we think that again, prioritizes both stability and consistency for members who have coverage through any of these dental carriers. I'm nearing the
Chris, can I just ask a question?
Yeah.
So what's the basis for not requiring Blue Cross to offer a non-group product, and might we reconsider that?
Sorry. So for a number of years now, the Health Connector has made available a process where carriers are able to propose plans, but also request a waiver to sell those plans on the shelf. It's something that was detailed in the plan year 2025 seal of approval process as well. And Blue Cross Blue Shield of Massachusetts has taken advantage of that process in requesting a waiver again for plan year 2025.
Yeah, I think over the last year we've reconsidered our policies towards letting carriers pick and choose which parts of our shelf they want to be on and which ones they don't. And we did that last year with the requirement that a couple carriers, including Blue Cross, come into ConnectorCare. So I'd love to put that on the agenda for. I know it's too late for this year for the seal of approval, but it seems odd that Blue Cross, which has a lot of dental business, doesn't sell on our non-group shelf when it does on the group.
Noted, Nancy. And I think to your point, I think it's a great opportunity for us to take a look at, any of our carrier participation requirements or who is on what aspect in providing a product through the shelf here, who is offering what to what end. So I think that it's noted, and for future years, it's something we'll definitely take a look at. Any other questions on the overall product shelf, the submissions, the seal of approval process before I transition?
Eric's hand is up.
Hi, I was just going to add a thought on the dental. With the recent dental loss ratio rules being implemented, from our perspective in the private marketplace, we're seeing carriers having difficulty maintaining their positions in the market for small group and individual coverage. So I'm actually pleased to see that Altus and Delta are still offering individual dental and can do it while complying with all the rules in the state. So while it'd be great to add additional carriers, I would just note that the general marketplace is going in the other direction, where we see carriers exiting the Massachusetts marketplace for small group. So we'll have to keep that in mind.
Noted, Eric, and I think that the overall market environment is something that we absolutely need to consider as we think about what the available products on the connector shelf. Thanks for that. Okay, let me just do a quick scan to make sure I'm not missing anybody else's hand up. If no other questions on the overall seal of approval product shelf, I will pass to Marissa Wolfman to discuss the NCQA. Marissa, I'm not sure if you're talking, but I didn't hear anything.
Yeah, you're not on mute, but you were so faint. Hear me now? It's really low. I'm wondering if maybe we can have you call in to do audio. Kathy, can you just quickly get the phone number Marissa should call into?
Okay, I will do that. Hold on.
Thanks everyone for patience.
And I think if we could go back to a slide about the NCQA accrediting standards, so we have a common understanding. I mean, I think it would be good if Marissa went through that.
Yes.
I told you guys I was going to pipe up.
We welcome it.
Trying Feline, but
Can you hear me now?
Yes.
Yes, indeed.
Okay, great.
And Marissa, the secretary had just noted it might be helpful before we dive immediately in kind of what NCQA is, what their standards are, a little bit of table setting.
Sure. Let me go back a slide here. Here we go. Okay. So we'll talk through this issue with WellSense Health Plan. I would just like to start first by thanking Acting Commissioner Kevin Began for joining us today to answer any questions that the board might have about this issue from DOI's perspective, as well as the close collaboration from our colleagues at DOI, as well as Mass Health as this issue's unfolded. So we have included these NCQA standard categories here. So NCQA is an independent entity that provides accreditation to health plans and providers across the country. They are federally recognized by CMS for this work, along with a couple of other entities that do this kind of accreditation work to independently review the activities of payers and providers with regards to quality performance. So hopefully that's helpful. I can certainly add to that as we go. But from where we are right now, in May, WellSense notified the Health Connector that it was denied when seeking to renew its health plan accreditation with NCQA. And accreditation through NCQA or one of the other federally recognized entities through the U.S. Department of Health and Human Services is generally a requirement for plan certification by marketplaces like the Health Connector. And specifically, WellSense did not achieve a passing score in NCQA's quality improvement category and did not pass 3 so-called must-pass standards in the utilization management.
Here for the CEO meeting.
Oh, Michael, if you can go on mute.
Yes, yeah, Kara's all off on mute.
I would go ahead, Marissa.
Okay. So based on what we've learned from discussions with NCQA, WellSense failed the quality improvement module of the survey because of insufficient data to drive quality improvement strategies during the survey period. Additionally, NCQA identified issues related to documentation of procedures associated with provider credentialing and utilization management. Ensuring that members have high quality coverage is a paramount priority for the Health Connector. NCQA noted that their review of member case files showed that appropriate member-facing actions were taken, and based on our understanding of the issues at hand, members are not feeling direct impacts of this loss of accreditation, which is an important consideration for us as we move forward and something that we'll be monitoring closely. Subsequent to the denial of accreditation, a request for reconsideration by WellSense to NCQA resulted in NCQA putting WellSense on a path toward provisional accreditation that's conditioned on their performance against a corrective action plan, or CAP. Over the next 3 months, NCQA will meet monthly with WellSense to monitor their progress, as well as with state regulators to provide status updates. In late September, NCQA will consider whether progress against the CAP warrants an adjustment in the denied under corrective action accreditation status that is in place today. And that adjustment could result in a provisional accreditation status, a continuation of the current status, or other adjustments. Beyond NCQA's engagement, DOI has also been actively engaged with WellSense on this issue, including examining the factors that led to the NCQA denial, as well as conducting its own regularly scheduled managed care accreditation process over the course of the summer and fall. But just to be very clear, those two accreditation processes, DOIs and NCQAs, are separate processes. The Health Connector has issued a letter of noncompliance to WellSense on this issue, conditioning further consideration of their participation on the Health Connector shelf on satisfactory performance against the requirements that NCQA and DOI lay out as part of their engagements. We've also been in discussions with our federal partners to keep them up to date on this issue. As we move through the summer, we'll remain in close contact with NCQA, DOI, and Mass Health in monitoring WellSense's progress in completing activities associated with their CAP. We plan to return to you in September with our final SOA discussion and report out what we've seen with regards to progress and a recommendation for 2025. Over the next several months, we'll continue to ensure members are receiving high quality coverage, and we'll prepare for any contingencies as we head toward open enrollment. So let me pause and see if there are any other questions for me.
Hi, Marissa. Since we've been looking at this issue for quite some time, do we have, as an entity, have a plan B should WellSense not address the concerns that have been raised by NCQA by September/October timeframe?
So that's part of the contingency planning that we're currently engaged in. So our open enrollment internal planning kicked off in earnest in June. We have a variety of work tracks that span the organization, and each of them will be factoring in to their preparation work any considerations should there be a shift in participation on our shelf.
Let me rephrase slightly. What are we going to do with the people who are currently using this product if this is not a viable product?
Sure. So if we do end up having a shift in participation, this would not be the first time that we had a change in our carrier landscape. And so we do have a variety of system functionality, member communication templates, things like that, that we would use to map people to other plans should they need to switch carriers. So that's definitely something that we're looking at, that we have done before, but would want to make sure that we've refreshed and ensured are ready for this particular plan year.
Thank you.
Marissa, is Kevin going to give us an update, or is Kevin here for us to ask questions of him?
Actually, both, and I appreciate Nancy. I did put my hand up. Thank you again for allowing me to be here today. I'm with the Division of Insurance, and we have made sure that this is one of our top priorities at DOI. It's required that the companies in the market notify us immediately when they have any change in status for NCQA. We were notified in May, as the connector was, and immediately initiated an exam. An external consultant has gone in to look and interview the company to determine all the reasons they may have actually had problems pulling their documentation together to meet NCQA accreditation. We are in the midst of putting together a final report and a corrective action plan. The company did have some turnover in key staff over the last 3 years. And because of that, we know that they did not have the appropriate level of resources and attention that were put to certain of the documentation categories. We agree with some of what Marissa has said regarding we do not have any complaints or any immediate concerns regarding patient quality, but we take this seriously and want to make sure that the company is taking steps quickly to make sure they are returning to full accreditation, and likewise, to make sure they're taking internal structural and communication steps so this will not happen again. So I appreciate being here today for questions, but this is something we are working closely not only with the connector, NCQA, but also Mass Health to make sure this is a company whose problems are addressed as quickly as they possibly can. So I know there may be questions, and I think that's why I agreed to help today to be available for them.
I see Nancy and Eric's hands up.
I think Eric's hand was up first.
Hi, Eric.
Okay, thank you. I've been thinking about this one a lot. On one hand, WellSense is an organization that has been a strong partner to the connector and to its members. It's serving a population that needs support. It's meeting the goals of accessibility and affordability uniquely among the carriers that we have on the connector. On the other hand, I've been in this business for 25, 30 years, and I haven't seen a health plan lose accreditation. So this is not a light topic. So I'm looking at this, and I know we're considering things for 2025, but I think we also should be thinking about our members in 2024. People who are on the plans now, and people who are every day going online, choosing plans and considering this as one of the options. So my questions are this, and Kevin, this might go to you as well. One, I just want to confirm there's no harm being done as a result of what we're hearing from NCQA. I want to make sure there's no harm being done to any members, or no potential harm short term to any members as a result of the issues NCQA found. That's one question. And then my other question is two-part. Do we have any legal requirements to do anything now, to let any members know now as to what's going on? And if the answer is no, we don't have a legal requirement, do we have an ethical one to let people know, hey, this is an issue out there for full transparency. We're working through it with the carriers and the DOI and CQA. Do we have an ethical obligation to let people know? So those are my questions.
If you don't mind, I'll try the first question, and I'll leave the second to actually the connector board. We know in talking with NCQA, they've looked very carefully at the WellSense BMC situation, and usually their status is denied or approved. They've looked at the NCQA status and acknowledged that this is a documentation issue that the company needed to address, and they've actually come up with a status that is denied under corrective action plan. NCQA has highlighted that they believe compliance with the corrective action plan will actually lead the company to come to a provisional and accredited status. So it is something NCQA has not given the signal that the company has been denied because of the fact they have done things that are causing harm to the individuals who are covered under the plan, but they need to take steps to make sure they're able to reach the score necessary to be able to meet the accreditation status. I'll turn it to Marissa to see if she has anything to add to that.
I think on that point, I think it bleeds into Eric's second question a little bit with regard to this being an ongoing discussion in some ways with NCQA, and you know, it is an unprecedented situation in our experience as well as the path that NCQA has taken here to work with the carrier in remediating these issues. So I think we've been also carefully contemplating how members engage with this process. And at this point, I think we're just considering getting some additional information over the course of the summer before reaching out to members specifically on this front, but we welcome input from the board on that as well.
Have we addressed it from a legal compliance perspective?
Andrew, if you're on, can you chime in on that?
Happy to. Good morning, everyone. So we certainly have reviewed the situation from a legal compliance perspective, Eric. You know, the simple answer is that no, we don't have a legal obligation to take any particular action based on this loss of accreditation. We certainly need to calibrate what our response is to the very serious failure that WellSense has demonstrated here. And I have been advising the connector on pathways forward. I think the position that we're in is one where we have flexibility and options to pursue the best course that preserves the quality of coverage that we offer to our membership. But again, to answer your question straightforwardly, no, we don't have a compliance obligation to take any specific action at this time.
I would also, oh, go ahead.
No, I was going to recognize the additional hands, Audrey, but why don't you go ahead and intervene?
Just ever so briefly, so defer to Andrew's take there, and just also for the board's awareness, since this is this relates to a federal requirement on marketplaces, I do want the board to be aware that we are in touch with and have since we first heard of this from WellSense with CMS, who is our regulator with respect to this space. And so want the board to be aware that as we're thinking about our pathways, we're in touch with CMS and obviously would not be making or contemplating any moves that they did not feel, were appropriate given the particular unique situation that we're facing. So please be assured that we're keeping them posted. And exposure in that way is not something that we're going to be caught off guard by.
I want to recognize Nancy's.
Oh, thanks, Feline. Kevin, thanks for coming today to give us more information about this. When you were speaking, you used the phrase pulling documentation together twice. And that was what was going on here. And I wonder if you could give us a sense. I think there are times when you don't pull documentation together because you have it and you don't do a good job putting it together. There are other times when you don't have the documentation, so you can't pull it together. So I'm curious what you can tell us about the nature of the documentation issues. The second question I had is the plan's also licensed in New Hampshire. And I'm wondering what the regulators in New Hampshire are doing and if they are taking a different tack, if the report that and the consultant that you all have hired is also working on behalf of New Hampshire. And then when is the report going to be done by the consultant, and will it be public and available to us?
Appreciate that. And I'll start with the latter and go backward. The report should be done within the next week or two. Yes, it's intended to be a public report, and it's available not only to the Connector board, but we intend to make it public for all. Regarding New Hampshire, we have been in contact with New Hampshire. We know that the Mass Health equivalent in New Hampshire has been following this very carefully. We have been relaying information to them. They are likewise looking forward to see the consultant report we pulled together. The Department of Insurance in New Hampshire has not yet delved into this because they are brand new in New Hampshire. They are looking to take our report and likewise use it as a corrective action plan going forward. Regarding the documentation, through many of the conversations we had with NCQA, we understand that there was information available for a year, but it needed to be available for 2 years in order to fully go through the quality improvement review. Through our conversations with the NCQA reviewers, they indicated that even though they did not see concerns with the 1 year worth of documentation, they just need the 2 years or they cannot give credit appropriately. Regarding the steps that were in place that led to the documentation, I think I'm looking for my report to come out, but I think much of the turnover we understood that existed within some of the departments that were coordinating this, it unfortunately led to the fact they just weren't able to pull together the more than 1 year's documentation. Now, again, that's not excusable. They need to have appropriate protocols, plans in place for individuals for succession when there is turnover. They need to do a lot more to make sure this never happens again. But that's what we have heard from NCQA and some of what we've heard likewise from our consultants who've gone in.
And Kevin, was the year that was available the most recent year, or is the missing data the most current period?
My understanding is when they looked through it, it was supposed to include 2021 and 2022, and the problem was 2021.
Okay, thanks.
I'm going to recognize Dimitri's hand is up.
Thank you, Feline. I'm looking at this and I'm having a hard time understanding how this is not impacting the communities served by WellSense, given what we are highlighting as concerning issues: quality improvement, utilization management, credentialing, and re-credentialing. Now, WellSense have been a great partner in the community in addressing the insurance need of a lot of disadvantaged folks. But when we're looking at those 3 pillars and we're saying there was a lack of competency, that the folks who were working in the organization, they walked out, and they walked out with the know-how on how things got done, which would infer that there was a lack of process somewhat within the organization to ensure that new folks who were coming in were following standards and following processes and following workflows that allow the organization to continue to function and providing quality service to the population that it's serving. We know that the population that's served by WellSense, for the most part, tend to be the folks who are not going to be complaining a lot or knowing where to go to complain in most instances. And so, again, I have a difficult time accepting that folks are not being adversely affected by this when we look at the population that is served by WellSense. And I don't know how we or other responsible entities in the state query those folks to get a better feel on how they're being impacted. We know that if providers are not being credentialed or re-credentialed, that means people who wants to provide services to the communities are not able to provide the service. So therefore, there's a lack of access that affects the folks who are in the least position to go and complain about not being able to access resources. So, so again, I don't know if it's us, I don't know if it's DOI, but I think the population served by WellSense is being somewhat overlooked, because if you saying quality improvement, lack of documentation, lack of data, utilization management, lack of documentation, lack of data, credentialing and re-credentialing, lack of documentation, lack of data. I have a very difficult time understanding and believing that the folks are not being adversely affected.
I'd appreciate it. I'll again lead and see if Marissa does have anything to add. This is not something that should have happened, and the carrier does need to take steps to improve this going forward. We have not heard credentialing problems from providers who have gone through BMC. We do monitor utilization. We do monitor claims payments. We do monitor many of the things that we know BMC is providing through the community. We have not seen red flags through many of the other things we are monitoring. We believe this documentation is something that needs to be corrected. We have understood through our consultants that they have new and appropriate plans and resources in order to address this going forward. I think it's the reason why NCQA is willing to go through the corrective action plan to allow the company to demonstrate over the next 3 months that all of the appropriate processes are in place that can lead to the company's change in status. But
Can you get me another?
But I'm not arguing the company did not do things that should have been done appropriately. We likewise agree with Marissa's original comment. This is unprecedented, and we at the DOI have never had anything like this come up. But we believe the company is taking steps, and over the next 3 months, we think that anything that may have happened regarding documentation is going to be addressed. But that's necessary for us to monitor and with NCQA to see whether it hits the appropriate standards. Marissa?
And again, I want to reemphasize the fact that I believe BMC HealthNet or WellSense have been doing a wonderful job in the community, and is an organization that we need to ensure that we provide the appropriate level of support to. But also it's necessary for us to take a step back to Eric's point, and while we may not have a legal obligation as it relates to communicating to our constituent, do we have an ethical obligation to address this, to raise this issue to our constituent, if for no other reason to be able to get appropriate feedback in terms of how is the community being impacted and affected by these issues that NCQA has highlighted.
I would just add on that front, we do have some recent non-group and small group member survey results that we can look to see if there are any disparities in reporting issues by carrier. CMS also requires that QHP issuers conduct a survey each year, and they translate that into quality star ratings. And we can examine that information as well. We haven't seen any disparities in that to date. More data on that will come out this summer. So we can certainly look at that and other ways to directly interact with members to see if they are feeling differently than what the evidence that we have so far here suggests.
And I would just add, I really want to thank Eric and Dimitri for the comments around, beyond compliance responsibilities, the question about transparency and communication in light of what we've learned, even if we do learn more and determine there was less member impact, et cetera. I think we are still in the learning mode and are looking to get more information about what transpired, as well as the path and the sort of current state of member interaction with this carrier. And And we are open to communication if that is what this board and you know, we think makes sense at this time, as opposed to waiting and letting more information materialize. There are certainly trade-offs in terms of, you know, how that gets communicated to members and what impacts that might have. But I do just want to note that is something we are also wrestling with as a staff around this question and this unprecedented situation. So I just want to thank you and agree with the spirit of the question you're raising, because I do think it's a challenging balance that the connector needs to strike here with respect to wanting more information to determine whether we think this is coverage that, you know, we stand behind, et cetera, as we're thinking about 2025. But if we learn different, what do we think is appropriate in terms of our communications to members? So very much looking to this board for counsel on that question, that I don't think there's a black and white place to look to for guidance, again, since it is unprecedented.
Thank you, Audrey. I want to recognize Michael and then Robin in the queue.
Thank you. First, I think Dimitri asked the exact right question. So I'll say, and I think Kevin gave a tremendous answer. I will say my take on this is I have actually I'm very open to the idea that accreditation results don't necessarily follow actual quality or things we care about. I think it is very plausible to me that you could do poorly on accreditation without actually doing poorly on the ground for a whole range of reasons. I'm not saying that's what's happening here, but it's certainly plausible to me that that could happen. And I think, therefore, I'm very supportive of all of the comments that were in the spirit of gathering more information and really trying to understand if our members are being ill-served in any clinical or customer service way or anything like that. I think that is actually fundamentally central to what we do. I'm sorry, in the transition from my phone to the computer, I may have missed some important material, but I think the question in my mind is I would probably prioritize stability in the absence of any evidence that there's actual real harm going on. And I wouldn't necessarily take the accreditation issue as evidence of real harm, because I would worry that things we might do that would create instability could actually have a much worse effect on the populations being served. It could break up clinical relationships. It could interrupt care. There's a lot of things that could happen if we if we create instability in the market, and we might be doing so with actually no evidence of any actual real problem. So where I am, based on what I've heard today, is in the category of let's gather more information and see if there actually really is a substantive problem on the ground in any meaningful way, and then we can decide what to do. But I wouldn't want to overreact at the current time. I would prefer to let the process legal, but we have to stay within the law. Right? So that's a given. And then I would let the rest of things play out as they seem to be, and decide once we have more information, because I do think the consequences of instability, particularly for a provider and carrier that are so important to our population, actually are really significant, and we shouldn't underestimate what might happen if we overreact to what might be an administrative problem.
Robin?
Hi, just a couple of things. One may be a question for Kevin, but as I was reading through some of the materials, it looked as though that they were doing a lot of the right things, but maybe they didn't have a written policy in place to document what they were doing. Is that correct? So, like, say, for example, on the credentialing or on the utilization management, am I correct about that? Is that part of the issue?
That's what we've heard.
Okay.
That they needed more documentation they had in place.
Okay. And then my second comment is just more around communicating to people. And I think my first reaction when I heard this is we should be telling people, but then if I think it through a little more, what exactly would we tell them? Because right now we're not even really understanding what the issues are. So we would, if we told them, I don't think it would be difficult to say what's happening, and I would prefer to wait until, let the process run through. That's all I had.
Thank you, Robin. There are no other hands in the queue, but I just wanted to just share some brief thoughts as well. Because I too, in the line of questioning and thoughts that Dimitri shared, felt very similar in terms of, understanding the reason, trying to understand the reasons for the denied accreditation, but also thinking about, the population. And, while I'm understanding there's no direct member impact currently, I'm also sensitive to any future member impact as a result of what currently is happening. And so, I am looking forward, eagerly awaiting to see the results of the report next week, Kevin, as well as the steps towards the accreditation plan. And I guess my question is, and I'm not sure who could answer this, really, what needs to be done to prevent this from ever happening again? Because I think what I'm hearing is what's being done to correct the issues, but in terms of, for this to never happen again, considering the significance of it happening today, I think, does that come out in a report as well? But I throw those out because, again, highly concerning, and just really, quite honestly disappointing.
No, thank you for the comment. And that's our major concern at the DOI too. We need to make sure they're able to address these issues today, but we're looking for them to have the structure, the internal communication, the prioritization, and the resources in place so that this will not happen again. I think the company acknowledges that perhaps they did not have everything in place they need to have going forward. And it's necessary for them to show us in reports that they've devoted the time, the resources, and also the right staffing to make sure this doesn't happen again. It's important for us to have that so that we know this is not going to come up on a year-to-year basis.
Thank you, Kevin. I want to recognize Rebecca.
Yes, I'm hearing what everybody's saying, and I completely agree with the concerns that are being expressed. I want to emphasize what a important issue this is to the division and how hard we've been working on it, and the consultants have been working on it. But one of the things I wanted to just let this audience know is that my understanding is that with respect to individual patient files and with respect to individual credentialing files that were reviewed as part of this NCQA accreditation, is that those files were all passing, and in fact were quite good. So I think some of the issues associated here really are documentation, minutes with respect to meetings, that sort of thing, that ultimately obviously will have impacts if it continues. But in terms of the short term, I don't think at this point in time that I've seen evidence that there has been a quality impact on patient care, which of course is paramount.
Nancy?
Kevin, a couple times you've talked about that they need to have the resources in place. And I have to assume that's a management issue, because this is a plan that's been tremendously profitable over the last couple of years. If memory serves, it made $136 million last year in profit. So when you talk about resources, I just want to be clear, it's how the plan is choosing to allocate its resources. It's not that it does not have resources.
And the key is staff resources more than anything. I think we're trying to highlight that there needs to be continuity so that if there is turnover, there's clear staff replacements, and to make sure that there's appropriate staff that's available to always make sure this documentation is prioritized in a way that it can then be available for NCQA to do their surveys. So it's the staff that's the most important thing.
Okay.
But there's always need for there to spend whatever consultant resources that help staff to make sure that they are putting this as one of their major priorities on a regular basis.
Yes, just to make the point, this is not a struggling, under-resourced plan that has not been profitable, and that has really not been the case for this plan for many years, and certainly not in the last couple of years. So, okay.
I want to recognize Eric.
Thank you. I just want to make sure I understand some of the facts. It might help us as we look forward. We're talking about how it might be it's plausible that it's just a documentation issue, kind of inferring that it's a little bit less critical than it otherwise could be. But they did get the denial in May, right? And then they had an opportunity to fix it over next month or two, if I recall. I just like clarity on that, so that they had a reconsideration opportunity. So they could have said, oh, geez, we forgot to do this policy, we forgot to do that one. Let's get those together and sort of give them to NCQA and get through this. I feel like I read that they had that opportunity and it didn't work. And so their reconsideration was denied. I just want to make sure of that and just reiterate from my opinion. I know you're pulling the board. I know it's a hard question. I always believe in full transparency. I always believe that people can make decisions on their own. You give them the right information. You give it to them fairly, evenly. Let them make their own choices. You know, when and this isn't about WellSense, any carrier that has an issue. Last year, Harvard Pilgrim had a huge issue with getting their data security, and the broker community, and me included, right in the newspaper, we asked for Harvard to just be transparent, do what they can, understanding that things take time to fix. But I believe in transparency in terms of communication. And if it were me, if I was buying a plan from my mom or my sister, I'd want to know, and then I can decide, hey, this is not that important. Sounds like it's being handled, and the plan and the providers and the cost are good for us, then that's okay. That's just my thought.
If I may, and Marissa and I learned more about the NCQA process than I think we ever did for the last month. The reconsideration process doesn't allow for the addition of new information. It only allows for a company using the exact information that was done in the survey to then argue for why that information should actually allow for NCQA to reconsider and accredit. It is something that they are taking advantage of the corrective action plan over the next 3 months to collect and present the additional information that we believe NCQA will reevaluate in order for them to then reconsider the status. But the reconsideration process was not a process allowing for the addition of any new documentation or any new information. It was only to look at what had been looked at during their survey.
That's very helpful. Thank you, Kevin.
Thank you for the question, Eric. Michael, you have the floor.
Thank you. It's interesting because I think we all agree on a lot of the same basic things, and then we disagree on certain things to emphasize. So I'm going to ask a different question. I'd be interested to know how the staff, or you, Kevin, how worried you are that, for example, if they left the shelf, if they left the marketplace, what the cost and quality of care and disruptions would be, and how concerned you are that, while I agree with Eric in terms of supporting transparency, I actually think there's a lot of behavioral economics work that suggests transparency is really an unbelievably challenging thing to actually do, particularly in this case when we don't know the severity, because you don't want to communicate this is no big deal, it's just an administrative thing where some notes were missed. That seems not very transparent. There might be a real problem, but you don't want to convey that there actually could be a real problem. You might want to switch if that's going to induce people to leave their providers and not get care and have a bunch of other things going on that actually really matters to their health. So you could actually, in the effort to be transparent, in fact, provide information that makes people draw the conclusion that is probably not the right conclusion. So I guess my general view is in supporting transparency, I do not think we can be transparent unless we know more about the implications of what the message we're trying to convey is, not just the literal facts, because I think even amongst this board, and I think we understand this pretty well, are struggling to interpret what this means. And we've spent, I don't know, 30 minutes. We've been able to engage and ask questions. It's not like we just got a letter, and I'm still a little bit unsure what it means. And so I think it would be very hard in a general communication to convey to people the right level of concern that they should have, and how much risk and care disruption should they undergo to avoid being part of the WellSense community. And I worry a lot about that. And I particularly worry about that given the tone of some of the things you've said, Kevin, which is there's a lot of administrative problems, but there don't seem to be now any clinical problems. And I don't want to create any clinical problems in our effort to avoid uncertain potential future clinical problems, particularly such an important carrier.
Yeah, I mean, I would only highlight, which I think you know, that BMC is a major company on the shelf, and much of their commercial business is through the connector. I highlight that they are taking steps that we've seen already and that they continue to take over the next 3 months, that I believe will have a more complete identification of what steps did not work in the past and what is being done over the next couple of months. So we'll have a much more complete array of information to present to the board when I think you're having your final decisions in September. I think it is difficult to explain certain of these things when we're still sorting through what they are. I think that the company is definitely taking steps to address certain of these administrative things, and you should expect that they are informing the connector through Marissa and her staff so they can likewise inform the board. I think it's important for you to continue to hear what the steps are that they're taking, how they are actually addressing them. And with these monthly meetings we're having with NCQA, as they are likewise looking at what steps the company has taken, they can advise us if there are things that are needed to go in a different or more emphasized fashion. So I think we have seen the company has taken steps. Our consultant will continue to point out the corrective action plan we believe is necessary going forward. I think we've heard the connector staff suggest that there be a continued collection of the information so we can present that to the board over the next couple of months. The difficulty has been timing, and I recognize that as we're doing this report, we've tried to accelerate things, and our consultant has done a great deal within 30 days, but we want to make sure we're giving information to the board and to the market that's based upon facts, as we can make sure they're clear and don't actually misinform the public about something that may be different when they hear different words in different ways.
Thank you, Kevin. I'm looking through the queue to see if there's any additional questions or thoughts. And I'm seeing none.
Well, I thank you for letting me be here today. I apologize. I do need to leave for another meeting. If there are follow-up questions for the DOI, I know that Rebecca or Marissa can always forward them to me, and we'll make sure we update the board accordingly.
Thank you, Kevin.
Thank you.
With that, again, seeing no hands in the queue, at this time, I think it's appropriate to call for the vote. And its vote is on the conditional seal of approval for plan year 2025. Such that Health Connector staff recommend that the Health Connector Board of Directors allow the 2025 conditional seal of approval to enable continued consideration of all recommended standardized and non-standardized QHPs and QDPs proposed by the following carriers, which are, as you see on the screen, Altus Dental, Blue Cross Blue Shield of Massachusetts, Delta Dental of Massachusetts, Fallon Health, Harvard Pilgrim Healthcare, Health New England, Mass General Brigham Health Plan, Tufts Health Plan Direct, United Healthcare, as well as WellSense Health Plan. And so with that, I defer to Kathy to lead the roll call vote.
Okay. Rebecca,
Yes.
Michael,
Fellaine, can I just ask a point of order? Did we have this put forward and seconded? Do we need to do that before we vote or no?
I'm just looking, you probably should.
I believe
Yes,
we need to.
we do need to. So with that, I will entertain a motion to approve.
So moved.
Second.
Thank you.
okay. Rebecca,
Yes.
Michael. I'll come back. Fellaine,
Yes.
Eric,
Yes.
Martha,
Yes.
Robin,
Yes.
Dimitri,
Yes.
Secretary, Nancy.
I'm going to abstain. Sorry.
Okay, thank you. Nancy,
Yes.
Erica,
Yes.
and I will come back to see if Michael has joined us.
I am having problems. I join you. I vote to approve if that is the question.
You are heard.
Thank you.
Thank
I
you.
hopefully I will stay heard, but maybe not. Maybe not, hopefully.
Thank you, everyone.
Okay, the motion carries. And at this time, I think I'm gonna return the chairing back to Secretary Walsh. Thank you.
Thank you, Fellaine. Thank you for covering for me. I'm glad I abstained because it was a real, I think it was a growth experience for me as a human being. I think I would have been far too involved and wanted to unmute and answer every question. I want to just offer up my thanks to this board for such careful consideration of such an important matter in such a thoughtful way. It was really impressive to listen to, and thanking the Connector staff and Kevin for clearly the work that both DOI and the Connector have done. I will offer that Mass Health has been part of those negotiations and has done similar work because we want the same process across all the people that we're responsible for in government. So thank you all. And this was an exercise in personal growth I don't want to have to go through again, but I'm going to cheerfully move on to the ANF update, which is going to be led by Carrie. Kari, thanks.
Thank you, Madam Secretary, and good morning to members of the Health Connector Board of Directors. The purpose of this presentation is to review our current fiscal year 24 administrative budget projections and present the recommended budget for FY25 for a vote. Considerable events have occurred since we last discussed this budget with the full board. We have completed the redetermination activities associated with the end of the public health emergency, and we have enrolled about 150,000 members that transitioned from Mass Health. Secondly, ConnectorCare eligibility was expanded up to 500% of the federal poverty level under the pilot program approved by the legislature. There are over 50,000 individuals currently enrolled in the pilot. We will review in more detail, of course, on upcoming slides, but at a high level, current fiscal year 24 budget projections are favorable compared to the original budget from last July. And the FY25 recommendation was reviewed and approved by the Administration and Finance Subcommittee on May 29th. Our recommended budget is balanced with reserve levels consistent with our auditor's recommendation. It also accounts for the contact center and technology services procurements that are currently underway and any potential budget impacts that we could see. Before we proceed, Nancy, I would welcome any comments that you would like to make, if any.
Oh, thanks. No, I think the budget's had a thorough vetting by the subcommittee. And I think we're very grateful to the work of Carrie and all of the folks on her team. So I think we're very comfortable with it. And as Carrie said, we voted to approve it and recommend it for the full board's consideration.
Thank you, Nancy. As Audrey mentioned at the top of the hour, on this slide, we will touch on how our budget links to our strategic plan and equity initiatives. With respect to the strategic plan, the budget aligns closely with the pillar, maintaining and strengthening organizational structure and stability. Our budget is balanced, and we have reserves available to help sustain financial operations if necessary. From an equity perspective, we dedicate funding to support members who are in greater need of assistance with and access to health coverage. Examples include the funding that is allocated to our navigators, our community specialists, and the language line within the contact center. We want to provide members with the support that they need, where they need it, and in their preferred language. If no questions, I will proceed to fiscal year 24. And hearing none. And someone, if I don't see any hands, but if I missed that, someone please let me know. So with respect to FY24, we'll start with enrollment. The projected enrollment reflects an 8% decrease compared to the projections that were shared back in July. The decrease is primarily the result of fewer members transitioning from Mass Health coverage to the Health Connector due to the flexibilities granted by CMS to Mass Health. In addition, our membership assumptions were quite vigorous given the uncertainties that existed in the beginning of the redetermination period. We currently have over 355,000 members enrolled in coverage, which is an all-time high for the Health Connector. And if there are no questions on enrollment, I will proceed to fiscal year. Oh, I see a question, I think.
Hi, Carrie. My question actually relates to the previous slide, slide 31. Or, yeah, slide 30, actually. In the category of combating inequity, I'm curious, especially on the, well, maybe both points, to what extent, like, what is the percentage of the budget that goes towards, like, these two bullet points in particular?
That is a great question. I am going to say close. It's a little less than 10%. But I can see, we can see those numbers on the next slide. But I will say that the funding that we have allocated and are recommending for the navigators and the community specialists is certainly higher than it was before the redetermination period.
Mm-hmm.
But I can get you an exact number, Feline.
Thank you.
Okay, so fiscal year 24. So this slide here provides a high-level overview of our FY24 administrative budget. I will quickly review the exhibit. At the top, we have projected member months, followed by revenue and expense line items. This is followed by two different views of our net position and reserves with and without the GASB adjustments. For us, this is mostly GASB 51, which reflects the one-time purchase of an intangible asset that is depreciated over its useful life. In our case, these are the implementation costs that are associated with our contact center and premium billing vendors. This view is consistent with our financial statements. However, in the middle, we also show a view without the GASB adjustments to provide a look at our net position and available reserves, given that the spending for this implementation for those vendors occurred back in 2020 and 2021. This view also provides additional context to our CCTF request for ongoing operations. Current fiscal year projections are favorable compared to the budget from last July. There's about an $8 million decrease in revenue, primarily due to carrier assessments because of lower than budgeted membership, which we talked about on the previous slide. With respect to the one-time CCTF, CCTF is Commonwealth Care Trust Fund, CCTF funding, we utilize this to make critical investments in outreach and contact center supports to support our members during the redetermination period. The final amount was less than projected, so hence the decrease there. There's a reduction in expenses as well, which I will discuss on the next slide. Our net position remains unfavorable, which is expected, but our reserves are around $57 million. And if no questions here, we can look at the expenses in more detail. So this slide provides details on our expenditures. The largest decrease that you see here is for contact center and premium processing. This is primarily the result of fewer members, as our vendors are predominantly paid on a per member per month basis. There were also lower expenses for our customer walk-in centers. With respect to the Health Connector share of the operations and maintenance costs for our shared eligibility system with Mass Health, which is the HICS, our obligation for fiscal year 24 will be lower than budgeted as communicated to us by our colleagues at EHS. The favorable variance for our outreach activities and navigators is simply due to conservative projections that we had back last July, to be absolutely certain that we had the necessary resources to support members during the redetermination process. And lastly, the decrease in personnel and fringe is due to vacancies. So to your question here, Fellaine, navigators, outreach and education, we're projecting over $10 million. And the community specialists, I believe there's 4 of them, and they would be reflected in the personnel line. So actually, it's maybe a little more than 10%.
Thank you, Karen.
Thank you, Fellaine. If there's no further questions on FY24, I am happy to start with FY25. Hearing none, seeing none. Enrollment, we'll start here. So fiscal year 25 enrollment reflects a 21% increase compared to last year. This is due to the termination of some of the flexibilities that were granted to Mass Health by CMS, as well as continued expected membership growth. By next June, we are projecting just over 393,000 members, of which about 300,000 are ConnectorCare members, including those in the pilot program. And if there are no questions on enrollment, I'm happy to move to the recommended budget. So here we have, again, a high-level overview of our FY25 recommended budget, which is compared to the current FY24 projections. Revenue is expected to increase by about $23 million. About half is an increase in carrier assessments based on projected membership growth, as well as projected rate increases. The remaining is a recommended increase in the CCTF funding to account for any potential budget impacts due to the ongoing procurements. Expenses are projected to increase by about $19 million, more on the next slide. And at the end of the day, our fiscal year 25 recommendation, as Audrey mentioned at the top of the meeting, reflects a balanced budget and estimated year-end reserves of about just over $53 million. And if no questions, we will review the projected expenses for 25. As you can imagine, the largest variance here is for contact center and premium billing due to the ongoing procurements. We will certainly know more in the coming months, and we will update our budget accordingly, as well as the request from the CCTF. This increase also accounts for the membership increase that we discussed 2 slides ago. The decrease in funding for navigators, outreach, and education simply reflects the end of the one-time activities that we engaged in to support members during the redetermination period. And we are projecting an increase in personnel costs. Additional operations and IT staff were needed during fiscal year 24 to address critical business needs, and we will realize a full year's cost of these positions in FY25. In addition to that, as we just talked about, we've also established a new community specialist program to help members in their communities. 3 new positions were added for fiscal year 25, and they are to support our enhanced data and analytics program, as well as compliance efforts. And lastly, with respect to consulting, this reflects efforts to improve our internal business documentation, as well as supports for the implementation of our enhanced data and analytics platform. So I'll stop there and see if there are any questions.
Doesn't seem like there are any. I didn't see a vote in the deck. Is there a vote on this budget?
Yes.
Oh, there it is. Oh,
Yes,
there we go. All right. Next page. So I think if there's no questions, I'll call for a motion and say, oh, sorry, Eric, I didn't see your hand. My apologies.
Oh, thank you, Secretary. Just a question as I'm looking at the expenses. Is this, as you look forward, do you expect, because of all the increased need over the past year that we're realizing this year, do you expect this number to come down in, say, fiscal year 26, or is this trajectory what you expect to continue?
And when you say this number, I'm assuming you mean the total expenditures of 113. Yes. Thank you. I would not expect this to increase because this accounts for, again, we have allocated funding for any potential budget impacts because of the ongoing procurements. We've made assumptions about what we could potentially need for implementation costs, as well as if we need to run a couple of vendors concurrently. So there are some significant one-time costs in that contact center line item. So I would not expect future years to have the same trajectory.
Thank you.
If there being no further questions, can I get a motion and a second, please?
So moved.
Thank you. I'll take Dimitri as a motion, Feline as a second. And Kathy, could we please have a roll call vote?
Of course. All right. Rebecca,
Yes.
Michael,
Yes.
Feline,
Yes.
Eric,
Yes.
Martha,
Yes.
Robin,
Yes.
Dimitri,
Yes.
Secretary,
Yes.
Nancy,
Yes.
Erica.
Yes.
Thank you, everyone.
Thank you all.
Thank you. So we have one last item on the agenda. Thanks everybody for hanging in there with us. This is an important update on the ConnectorCare expansion pilot, which will be presented by Signe.
Great. Thank you. Let's get into the slides. Control. Here we go. So good morning. Today, I'll be sharing a status update on the ConnectorCare expansion pilot, including enrollment and demographic information, as well as insights on healthcare use, affordability, and access from a recent member survey. We have more than 50,000 individuals enrolled in the ConnectorCare expansion pilot, which covers people between 300 and 500% of the federal poverty level. The ConnectorCare expansion grants them access to lower premiums, no deductible, and low cost sharing. Overall, pilot members are generally demographically similar to other ConnectorCare members, and we'll note some differences throughout. The recent survey data highlight affordability and access improvements compared to prior health coverage experiences. And importantly, this spring, CMS approved federal match for state spending on the expansion through the state's Section 1115 Medicaid waiver, which cuts the state spending for this program in half. In terms of alignment with the strategic plan, the ConnectorCare expansion pilot primarily supports two of the Health Connector strategic plan pillars, including delivering high-value coverage options to residents of the Commonwealth and improving equitable access to affordable health insurance coverage. We believe the ConnectorCare expansion is also working to center equity by increasing affordability of health insurance coverage for Massachusetts residents with no deductibles and low co-payments. This is particularly helpful in advancing equity due to barriers to access and affordability faced disproportionately by Black and Hispanic residents in Massachusetts. Lower premiums and out-of-pocket spending enables members to use savings towards other household expenses, which has a compound effect in communities of color, given disparities in household wealth. And providing greater access to low-cost primary care and behavioral health services to counter disparities in access to preventive care, as we see higher avoidable emergency department use among Massachusetts residents who identify as Hispanic or Latino. So as of June 2024, there are about 51,000 members enrolled in the ConnectorCare expansion, which includes members, again, between 300 and 500% of the federal poverty level. As you can see, if we look at enrollment as of June 2023 compared to June 2024, many of the ConnectorCare expansion members would have been eligible for federal APTC only. So we have seen a significant decrease in the APTC only population since the start of the expansion, along with overall increases in enrollment across the board coming out of the public health emergency unwind. Overall, the ConnectorCare expansion pilot population represents about 16% of total enrollment in health plans through the Health Connector. Overall, we see that yes, Eric.
Just a quick question on the prior slide. If we deduce the numbers, does that mean if you had 37 versus 6 on the APTC, and if you figure that's 31 that moved over, is that 31 out of the 51? So then do we say roughly 20,000 new people enrolled?
Yeah,
as part of the pilot?
we'd have to look carefully to know exactly if those people have moved over, which we could do. But I think earlier numbers had about that representation of new members, but we could get the number for you to be sure.
Thank you. All set.
Thanks. So overall, we see that expansion enrollees are demographically similar to the original ConnectorCare program. So about 1/4 of ConnectorCare expansion enrollees, or 26%, are between the ages of 55 and 64. This is similar to our up to 300% population, which is about 22%, but lower than the APTC only group, in which enrollees between the ages of 55 and 64 represent 43% of enrollees. More than half of enrollees in the ConnectorCare expansion are between the ages of 26 and 54. And notably, one of the biggest differences in the ages of the ConnectorCare expansion population is the under 18 age group, as about 12% of enrollees in the expansion are under 18, compared to less than 2% in the under 300% FPL, as many of those folks tend to be covered by Mass Health or CHIP. ConnectorCare expansion enrollees are about 52% female, 48% male, slightly lower than the 57% female rate for the up to 300% FPL group. And data on self-reported race tells us the ConnectorCare expansion population is about 57% white, about 8% Asian, about 5% African American. However, more than 1/4 of enrollees, about 27%, either choose not to answer, report that they don't know, or leave that question blank. So we still have some work to do on our race data. The up to 300% ConnectorCare population is closer to about 40% white, 11% Asian, and 9% African American. Again, more than 1/3 of enrollees in that group choose not to answer, don't know, or leave that question blank. More than half of all enrollees are enrolled in Tufts Health Direct, about 55%. This is very similar to the up to 300%, which is about 53%. Similarly, we see WellSense as the second most popular carrier, with more than 1/4 of total enrollment, about 27%. A little bit lower than 34% for our up to 300% group, followed by MGB with 8%, which is just slightly higher than it is for an up to 300% group at about 6%. 3 out of 10 enrollees, or 30% of the ConnectorCare expansion population, are coming from Mass Health since April 2023. This is a slightly lower rate than our up to 300% group, which has about 37% of members coming from Mass Health. But in contrast, only 1 in 5, or 19% of enrollees with APTC only, are coming from Mass Health, and this drops to fewer than 1 in 10 for our unsubsidized enrollees. Notably, 7 out of 10 June enrollees, or nearly 73% in the ConnectorCare expansion, have been enrolled continuously at the Health Connector since January 2024. And this just means they have been enrolled in something at the Health Connector, not necessarily the expansion.
Signe, would that mean if they dropped out, would that mean they either went to a lower income category or they went to employer-sponsored insurance? Like, if you just got this, why would you move? It's been less than a year.
Yeah, so it depends on what happens. If they could have gotten a job, yes, exactly. And we see in some of the responses, in the open-ended responses, folks talking about the transitions in employment and this kind of coverage. So that would be my hypothesis.
Thank you.
Yeah.
Signe, may I ask a question?
Yeah.
I'm having trouble, or I'm not quick enough to put all the pieces together. Of the people who are in this group, it looks like almost all of them were insured before. They just are taking advantage of subsidies, or what do we know about that in terms of prior insurance status? 3 out of 10 came from Mass Health.
Yeah, I have a slide coming up from the survey data that gets at their prior coverage. Yes.
Okay. I will wait with bated breath.
Great, thank you. And it's helpful to get a sense of the relative contribution to premiums among the ConnectorCare expansion enrollees. So these represent the average per person premiums for ConnectorCare expansion enrollees as of June 2024. The blue represents the average net premium after both federal and state subsidies are applied. So this is what people are actually paying. We can see that the federal APTC amount in orange decreases as income goes up, and the state premium subsidies in green increase slightly at the higher income levels.
Question on this slide, is this monthly or yearly?
So this is a snapshot of June, the average for
June.
June enrollees. Yeah. Okay, so let's turn to the survey results. So we recently fielded a survey of members enrolled in the ConnectorCare expansion. It was sent to about 30,000 members with usable email addresses on file, and 2,434 members responded, about an 8% survey response rate. Among the respondents, about a quarter of them came from Mass Health, so about 23.5%, slightly lower than the overall population at 30%. 7 out of 10 respondents were in Plan Type 3C. We see this as consistent with our overall population, where 71% are in Plan Type 3C. And we see that folks are using care. So nearly 9 out of 10 respondents reported that one or more family members have used healthcare services since enrolling in ConnectorCare this year. Among those that have used healthcare services, 1 in 5 reported that they received preventive care that was missed or put off before. And we also see that more than half of respondents are employed in some way. Importantly, a requirement of eligibility for federal and state subsidies through the Health Connector is that individuals do not have access to affordable health insurance coverage from an employer. But we note that 52% of respondents report they are employed full-time. Another 17% report that they have 1 or more part-time jobs. And we also saw that of the folks who report either full or part-time employment, 36% report that they work for a small business with fewer than 50 employees. 22% reported they're self-employed or own a small business. And 11% report that they work for a nonprofit organization. So here's a snapshot of what folks reported as their prior sources of coverage, and this was asked for their 2023 coverage. So we saw about 38% reported being enrolled in ConnectorCare, another 20% reported being enrolled in something at the Health Connector, but not ConnectorCare specifically. About 12% reported having employer-sponsored insurance through their job or their spouse's job. About 11% reported being enrolled in Mass Health. This was a little bit different than our administrative data when we did the matching, which was closer to 24%. And about 4% reported being uninsured. I also want to note about 7% reported other, which was a mix of often COBRA, a mix of 2 or more types of insurance over the course of the year. So a shift from employer to Health Connector, being uninsured for part of the year, being on their parents' plan, and some folks wrote in their specific company or carrier for their plan type. And I just want to highlight here that respondents noted the value that ConnectorCare coverage provided to individuals and families, especially during employment transition. So we see here, as a self-employed freelancer, this ConnectorCare plan has been an absolute godsend. I have been able to continue seeing all of the providers I saw on my employer-sponsored plan and at a significant cost savings. I do not have any other alternative for acquiring healthcare coverage and was so worried when I lost my job that I would have to pay exorbitantly out of pocket or forgo health insurance altogether. Instead, I'm getting excellent care at a much more affordable rate and have so much peace of mind. Thank you for making these low-cost plans available to people like me who depend on them. As we noted, the majority of respondents have used care, and among the 88% who report that they or a family member have used care, these are the most 8 common reported healthcare services reported. So routine or preventive medical care was the most commonly, followed by prescription drugs and diagnostic tests. And not only are they accessing a variety of services, but some respondents also highlighted that they're now able to access care that they had previously gone without. Among those that have used healthcare services, 1 in 5 got preventive care that was missed or put off before because it was too expensive or hard to get. 1 in 10 picked up prescription medication that was not taken before or delayed because it was too expensive or hard to get. And 1 in 10 saw a specialist that was hard to see before because of network restrictions, cost, or other problems getting care. We also looked at the small number of folks who reported being uninsured in the previous year, and those rates were even higher. Among those that were previously uninsured, 35% got preventive care that was missed or put off before because it was too expensive or hard to get. 13% picked up prescription medicine, and 13% saw a specialist that was hard to see before. The majority of respondents were very positive about their level of access and affordability provided by ConnectorCare coverage. Specifically, about 80% agreed or strongly agreed that it was easy to find a healthcare provider that speaks their language, respects their culture, or both. 69% agreed it was easy to find a healthcare provider that accepted their insurance. And 86% agreed that the healthcare services received addressed their healthcare needs. 68% agreed that they could afford the copayment. While 2/3 of enrollees said copays were affordable, about 13% still struggled with out-of-pocket costs. And we see this general overall satisfaction with the affordability of coverage play out in the open-ended responses as well. So several responses noted the significant changes in affordability and copayments with their ConnectorCare coverage relative to previous coverage. Eliminating the copay for my mental health was very helpful, as that is the most important service to me. Because it was less than I expected, it provided mental and financial relief for me. I currently live week to week on my paycheck, so any extras are a hardship. It is only this year with a zero deductible that I feel like my coverage is affordable. My copayment for specialists was $90 for several years, and that was a struggle. Beginning in 2024, it's been $22. I don't know why there was a change, but it is much more affordable. However, some still note the high cost of healthcare services overall, especially in the broader context in the rising costs of everyday household expenses. Everything is so expensive. I've put off a lot of healthcare due to copays, referrals, etc. There are some things that have gotten more expensive that can't be put off: groceries, gas for car to get to work, heat, electricity. So healthcare has been put on a back burner. I slightly disagree because the cost is quite elevated, and even if I receive a raise in the hopes to offset the costs, the cost of the insurance then increases as well. It feels unfair, as it is not my fault that my job does not offer insurance benefits. At a time when household expenses are at an all-time high, more affordable healthcare coverage is helping members to stay afloat and keep up with other day-to-day expenses. About 1/3 of respondents reported that they had already experienced cost savings from their ConnectorCare plan, and another 13% have not yet experienced savings but expect to in the future. When we ask folks who reported that they have already or plan to experience cost savings in the future, 2/3 said that they plan to use those savings to pay for other household expenses such as food, housing, transportation, or childcare. About 28% said they plan to pay down debt, and another 27% said they plan to save for the future. And as captured throughout these quotes, members are using these savings to pay for the rising cost of food, rent, utilities, pay down debt, make car payments, pay for college, and save for the future. The structure of the ConnectorCare program was particularly notable to several respondents who highlighted the relief and peace of mind associated with lower premiums, no deductible, and low co-payments. The financial savings from my ConnectorCare plan have been such a relief. I now have more money in my pocket every month to pay down my student loans, pay for groceries and utilities, and save a little bit for the future. I'm also not as hesitant to go to the doctor, knowing I have no deductible and a $0 copay. In the past, I would have put off seeking care unless it was urgently necessary. I'm so pleased that after 15 years of being on the Health Connector, my monthly premium has reduced to an affordable rate. My co-payments are affordable, and I no longer have a crazy deductible after paying a ridiculous premium, and then having to pay the first $2,700 that was so unaffordable for so many years. I'm so grateful that you changed your policy and made it more affordable for the working class. Thank you very much. I do want to note that there were some responses throughout the survey that highlighted challenges that members do experience with their coverage. Specifically, some respondents referred to high deductibles for their coverage. However, enrollees in ConnectorCare do not have a deductible, indicating that they may be thinking about their pre-January coverage or have not yet used their ConnectorCare coverage. Some respondents referred to challenges finding a provider, requirements for referrals, limitations in access due to restrictive networks, having to wait a long time to get an appointment, or concerns with out-of-state travel. Some respondents coming from Mass Health noted the significant increase in healthcare costs and confusion regarding the process of changing coverage. And some respondents noted challenges reconciling their federal tax credits at tax time. So our next steps, the Health Connector will be publishing a report including these data later this month, and we'll continue to monitor pilot program trends as well as the fiscal year 26 state budget developments and legislative activity. And I'm happy to take any questions.
That was a terrific report. I think it's just so helpful to hear what people who were trying. It's just great. I know surveys are kind of painful to field and take a lot of staff time to get, to make sure they're valid, but I really want to commend you for the work. It's great. Thank you.
Thank you.
Yeah, I completely agree. There's nothing like hearing from the members to
it's really
really give you a sense of why this is so important.
No, it's
and
like
what
a
a difference
shot
it
of
makes.
B12.
It
Yeah.
is, exactly, exactly.
Which I guess, I don't know if it's covered or not, but anyway,
Yeah.
it was great. But, oh, Rebecca, I'm sorry, I didn't see your hand.
I am having trouble with my reactions today, but I just wanted to say thank you. I also really appreciate hearing back from the members. And one of the issues I saw was regarding out-of-state travel questions. And while I'm sure there is some percentage of population that is doing extensive travel or staying part of the year in another state, where they might want to have regular care, which might not be in network, I would guess a lot of people are concerned about emergency care when they go on a trip and may not understand that emergency care should be covered regardless. Now, obviously, there might be some ramifications for international travel, but for the most part, emergency care should be covered. So that might be something to point out when we have further communications on the policies in the future to participants, that they don't need to worry about going to an emergency room when they are out of state.
Thank you for
Thank
that.
you. That's an important point. No, like, health insurance is hard to understand when you do it every day. So, so it's great to remind people of that. Thank you. I'm conscious of the time, and I'm gonna, I actually have to chair another meeting at 11. So if there's no further discussion, I'll just offer again the board's thanks to the team for all the great work. It was a really good and productive meeting, and we had a great discussion. So thanks to ourselves as a board for digging into some meaty topics. And with that, I will ask for a motion to adjourn.
So moved.
Second.
Thank you. And Kathy, we need a roll call vote. And I'm going to have to click off right after that. So I'll say my goodbyes.
Okay. All right. Rebecca,
Yes.
Michael,
Yes.
Elaine,
Yes.
Eric,
Yes.
Martha. I'll come back.
Yes.
Okay. Robin,
Yes.
Dimitri,
Yes.
Secretary,
Yes.
Nancy,
Yes, and stay cool, Kathy.
and Erica.
Yes.
Okay. Thank you, everyone.
Everyone, thanks so much.
Thank you all.
Thank you.